Good morning, everyone. My name is Frank Jaskulke with the Medical Alley Association, and I want to say a thank you for joining us today for what should be a very fun discussion and a very enlightening discussion. We've got a great group of panelists here with us today to talk about this idea of software is eating the world, including eating the healthcare world. As we go through this event, just a couple of things. So first, if you have questions, use the Q&A function. I'll be watching those. I'll filter the questions. I'll make sure we get to them and ask our panelists those questions as you put them in there. Second thing, please have empathy for what we're doing. We're still all in the Zoom world. Most of us are at home or in some remote location. There might be internet connection issues. I might have a cat or two show up. Things happen. We're all good with that. And then third, because we always get asked this, the event is being recorded. You'll be able to watch the webinar afterwards, or if you have colleagues who want to see it, make sure you share it with them. And with that, we're going to get started. The topic for today is around this idea of software is coming into everything, right? It's in the business world, it's in healthcare. We use software everywhere, we get that. But it's changing fundamentally the way we develop new technologies in healthcare, the way we deliver care, the way we pay for it. And that also means then the strategies we develop, the way we partner with each other is changing. We've got a great group of panelists that represent kind of the breadth of the Medical Alley ecosystem today to talk about that topic, share some of their experiences, and hopefully help us be a bit more informed and think differently about the work we're doing. To start, what I'll do is I'll ask each of the panelists to just briefly introduce themselves, a little bit about their background and their organization. And Anne, I'll ask you to start us off.
Great, thanks, Frank, and thanks for having us. So I am the CEO of Odonata Health, and we are developing a new device for fetal and maternal monitoring that is enabled with AI and also machine learning to actually give clinicians a lot more data. It's built on a very large data set. We actually grew out of a project that we started about 3.5 years ago with Mayo, a very interesting project that was cross service lines, particularly with OB/GYN, as well as cardiology, led by Dr. Paul Friedman and Dr. Kyle Trainer. So it's been a fun journey, and we're excited about where we're going with this platform. And the platform itself can be used in labor and delivery, but most importantly right now is a prenatal care telehealth platform.
Oh, very cool. Thank you. And then Nima, if you would.
Thanks, Frank. Appreciate you having me here today. My name is Nima Ahmadi. I'm the Senior Director for Digital Products at Cardiovascular Systems, which is a medical device company headquartered here in Minnesota. Prior to CSI, I've spent my healthcare career in software and analytics. I founded a care management software company, grew and sold a population health analytics company that was powered by AI, and here in Minnesota helped grow Novu Health into one of the largest patient engagement companies in the country, managing 15 million Medicare Advantage and Medicaid patients on behalf of the top insurance plans.
Thank you, wonderful. And then John, if you would.
There we go. Hey, John Helamka, president of Mayo Clinic Platform. For 25 years, I was the CIO at Harvard Medical School and its associated hospitals. Moving to Mayo with Platform, I'm now in charge of the Google joint venture and many exciting innovative developments in the fields of AI, telemedicine, and remote device and patient monitoring. Glad to be here.
Thank you, wonderful. Well, the place I want to start with the discussion is kind of reflecting on this topic around the idea of software is eating the world. And attendees, the way we're going to go through this is starting with a discussion of like what each of the organizations is doing today, talk about the environment that we're in and how it's changing, and then we'll get into some more meatier topics around like the digital divide, about strategic partnering, and close out with your questions as they come in. So the first question I want to ask everyone, and Nima, maybe I'll start with you, is just if you were to reflect on this idea of software is eating the world, the statement Marc Andreessen made now about a decade ago, I think, what does that mean to you relative to the healthcare world and to the work you do?
I actually take a little bit of issue with this expression because I think it centers software instead of centering the patient, and feels more like a takeover than really focusing on the patients and the providers who take care of the patients. And, the way I look at healthcare is that it's a complex, highly regulated services industry at its core, and software is really just an enabler. And to extend the eating metaphor, I think that's part of the reason why a lot of software entrepreneurs are having a little bit of indigestion when it comes to healthcare, because it is such a different industry for software, and it needs, a little bit of humility in that regard to understand how it's part of a much broader solution rather than a silver bullet.
Oh, that's a great point. Yeah, we can't just techify everything and expect a better outcome.
Exactly.
Yeah. And what about you? How do you reflect on that statement?
Well, and I agree with what Nima just said. But if you look at what's going on with medical technology and you look at the transformation over the past, 20 years, we used to have these medical devices that, you could capture information, and we needed software to do it. But now is so much bigger and so much more broad in the fact that we're capturing data. And now we have the ability with algorithms and machine learning to actually assess this data, give clinicians a lot more information, and it just really truly improves the care that we can give the patients long term.
Well, that's a great point. And this is something I've heard from many people in the device world. They're like, we've always had devices that generated data. There was always software, but we didn't necessarily do something more than deliver the specific therapy to the specific patient. So, John, you're a clinician, you're in this world. How do you reflect on this idea of software eating the world and, the data deluge that might be coming in?
Well, so a couple of points for you. As you can guess, clinicians have 11 minutes to see a patient, to enter 140 structured data elements legally required for every visit, be empathetic, make eye contact, and never commit malpractice. It's impossible. And so giving them more data is not going to be helpful. Giving them wisdom is what you really need. And that is separate the wheat from the chaff, filter this massive amount of data into something that's actionable. And so it's sort of funny that you mentioned Marc Andreessen. So yesterday I had a 3.5 hour call with Marc Andreessen, and we were chatting about AI algorithms that are going to change the way we practice. And of course, the big issue is the bias that those will introduce. And the worry that you have as we are transferring this new data stream into wisdom is that we are going to provide insights that are not applicable to the patient in front of you, that may suggest too little care or too much care. And we may not even know how algorithms were developed and what data sets they use. So I would say, sure, software is key, but we need to ensure the software we're using is fit for purpose and is going to reduce clinician burden, not increase it.
All right, I want to follow up on that a bit and talk about the Mayo Clinic platform and the work you're doing. I've had, you could say, the misfortune of being fortunate to be a patient at Mayo Clinic and have that experience, and a large, complex health system treating complex patients. Your team is working on building this platform for care. Can you talk about first, what is Mayo Clinic platform? And what does that mean for, generating wisdom that truly is wise?
So why don't we start off with generally what's a platform? Of course, everybody who would be affiliated with Medical Alley knows what that means, right? The idea that back in the day, we used to look at the Star Tribune to find an apartment for rent, and it was a single transaction by a single person on a piece of paper. And then Airbnb came in and said, no, we're going to automate at millions of person scale those that have places to rent and those who want to be renters. Well, platform is very similar in notion that what are the modules and components you're going to create that will enable novel workflows in healthcare? We started with 3. So the first is a clinical data analytics platform, the idea that you can, in a privacy protecting, ethical way, take the data of past patients and use it to generate new cures and treatments for patients going forward. And this is done in collaboration with Google, all de-identified data, all under Mayo control. So a set of platform components for reuse of data. Second platform was deliver care at a distance that's serious and complex. This is not just a Zoom kind of thing. It's how do I do remote patient monitoring, algorithms and dashboards so that we can take the sickest of the sick and care for them in their homes. That's the home hospital componentry. And then the final one, and one that I think is consistent with what our other panelists are working on, is how do I ingest new types of data from sensors and devices and turn that signal into action? And what are the components that you need? And, you know, I know this is like totally unreadable, but that's all it takes. Don't worry. Lots of moving modules to take raw signals from a device that you might be wearing into an action that a clinician or algorithm might take.
Very interesting. And Anne, I want to ask you a follow-up related to that. You're building a company that is, well, generating data, trying to turn the noise to signal to wisdom. And what's that experience been like? How are you going about it? And coming from a device world into a software world, how has it been different?
Yeah, so, you know, initially we had this premise that we were going to build a device and utilize fetal ECG and assess that ECG for changes that could be detrimental to the fetus. And what we were doing was building it off of the work that Mayo has done very successfully in cardiology. So basically, we had to build a medical device that could capture a fetal ECG and maternal ECG. But then you have to actually build your algorithms, you know, to assess those. And of course, the more data that you have, the more accurate your algorithms are. So for us, what we did was, you know, just focus on, let's capture the data, use open source data, let's test our algorithms. And that's kind of where we're at right now. We're very, very close to being done with this. But long term, what the strategy is, you know, as we monitor patients, we are capturing so much data. And it's really these algorithms that long term can help give some indication to clinicians that they're, you know, a fetus could be in distress. So that's kind of, you know, it was really built on having a device that can capture data accurately, but then it's all the software and the algorithms in the background that are actually making it smarter.
Yeah. So kind of related to that, then Nima, you talked about this notion of like, we need to be human-centric, patient-centric, and software is an enabler of it. You mentioned at a prior company, you'd helped to build a patient engagement platform that was serving 15 million people. You know, how do you deliver something that is truly like person-centric when you're at that sort of scale? And does software make that easier, harder? What's your like mode of thinking in doing that?
Yeah, I think that you pretty much said it, Frank. When you have the ability to use software and all the data that Anne and John are talking about, you can deliver individualized experiences in different channels. In the patient engagement business, you know, companies think about how can they deliver the right message at the right time to the right patient based on their specific needs, and how they have that 360-degree view of who that patient is, where they are in their care journey. That's all enabled through information that is transmitted, stored, and leveraged to deliver individualized experiences. From a medical device industry standpoint, you know, medical devices, you know, they're thinking about how they can develop, you know, new medical devices that are smart and intelligent for the point of care in the treatment setting, as well as remote monitoring solutions like what Anne is working on, which I think represents one of the best types of approaches where it's highly focused on a particular patient population, a particular condition, and a solution that is integrated and interoperable for that state, which I think is exciting. And it's great to have some of the pioneering companies in that vein started here in Minnesota too, like Anne's.
Heck yeah. Yeah, kind of a related question to that, and John, I'll ask this of you because I think it relates to the platform. We had a question in the audience about data coming from different devices or different sources in that integration. I imagine that's a challenge today. Is that something that you guys are looking at in being able to bring in multiple sources of information and make it usable for that, 11-minute, 140 measures that you've got to capture?
Well, sure. So a couple of challenges for you. So first, let's start with the provenance of the device. So Anne, I see you're wearing a Fitbit. I'm making this up. And her heart rate right now is 20. Oh, Frank, you better call an ambulance because her Fitbit says her heart rate's 20. Well, what are the performance characteristics of a Fitbit? Should we trust its heart rate? Well, what if it said heart rate 20 at 10:18 and heart rate 120 at 10:20? Oh, well, that's just expected variation. Don't act. But if it said 20, 20, 20, 20 for 5 readings in a row, maybe then we'd have to act. So the challenge is for this country right now, for all the kinds of devices you might deploy, there isn't provenance information about precision and accuracy. And so we're unfortunately flying blind a little bit. And we're going to have to, I think, as a country, start to develop some community standards as to when we act on data and when we don't. But the other issue is data standards. So although there are great standards for many aspects of electronic health records and images, as I'm sure Anne lives the dream every day, how many standards are there for real-time continuous telemetry? Not a huge number. And so every company is coming up with some proprietary approach. So the challenge we've had to do is we build adapters that are able to normalize multiple data streams in certain fields like cardiology into a common data format that then can be used with an algorithm. And we've done some proof of concepts on this, but it's no question work our whole industry will do over these next couple of quarters.
Oh, it's very interesting. It sounds like the development of a lot of different industries where it starts out with so many different approaches to the same problem. And so you get interoperability issues and hopefully over time converge on some, whether intentional or unintentional, standardized approach so that the innovation can focus on the delivery of the service, not we captured your heart rate appropriately. I'm curious in kind of this environment that we're operating in, which has a lot of impact on how we might collaborate. I don't want to talk about COVID too much, but I do want to talk about we're doing this from Zoom. We're often working from home. The pandemic has changed a lot of the ways we interact with each other. And we know that's changed the way we interact with the healthcare system. And the technology you're developing enables that, but it sounds like there's also been some focus in the telemonitoring prenatal space because of that. I'd be curious for the group, and Anne would love to start with you to comment on the changes that have been wrought by the pandemic relative to like telemedicine, remote monitoring, all of that. Is it permanent? Is it sustainable? And if it is permanent and sustainable, is it the right shift for us to have made for the delivery of healthcare, for the receipt of healthcare? Anne, if you wouldn't mind.
Yeah, so I'll give you a little bit of my experience just going through the whole product development process. When we first started out with this technology, we were really focused on labor and delivery and providing a device that gives more reliable data, fewer drop-offs, and then assessing that data, utilizing the algorithms for better information. So that's where we had started. But interestingly enough, I would take the device, I'd show it to different physicians, and many of them, particularly the physicians that deal with high-risk pregnancies, were looking at it and basically saying, can I use this in the home? It's wireless, so that started planting the seed. So we actually started doing more work to determine, where is the market need specifically with telehealth. And with OBGYNs, it was pretty split. Some people just really did not want to embrace it at all, and others did. So we basically put it in our product pipeline. So we started working on it, but what happened with COVID was that even the physicians that said, absolutely not, we don't want to manage our patients low risk or high risk in the home. We want to see our patients. We're actually completely doing a 180 and coming back to us and saying, we need to figure out how we can touch our patients remotely and get data from our patients, because they basically were relying on phone calls, calling them, asking them how they were doing. Is their baby moving? Are they feeling okay? And it's really just not the right type of care for prenatal care. So we actually did a really quick pivot so that we could get our device integrated into a platform. And then you ask the question, is it here to stay? Well, quite honestly, I do think, and what we're seeing and what we're hearing is patient satisfaction is up. They really do like to be managed remotely. And this isn't just in my area, it's across the board. And in the areas where there's a really good patient management process for remote care, it's actually received pretty positively on the provider side as well.
Oh, very interesting. And Nima, I'd be curious from your side, like we're probably not going to get, say, an atherectomy at home anytime soon, but I have to think it changes the way you think about the interventional world, the way you might engage patients. Like, how does the remote care and the pandemic change the way you think about even maybe more traditional device world?
Yeah, I mean, the traditional device world has always been focused on disconnected, sometimes disposable, otherwise heavy capital equipment at the point of care, right? And even before this pandemic, there was a lot of innovation and activity around how you can build devices that follow the patient along the care continuum. And we've seen great examples of that in, heart failure, heart rhythm monitoring, out of innovation here in Minnesota and in other areas. And I think that, what this pandemic has done is that it is accelerating adoption of remote monitoring and telehealth across the board and creating a catalyst that's going to shift the operating model in healthcare. Now, the data, when you look at it, like last year, the Commonwealth Fund reported that in April, telehealth went up to about 15% last year. It came down to 8% of, the patient visits from the prior year. So overall adoption of telehealth is still low. And, in order for that to change and become more of the mainstream, that's going to require, time, because it takes a while for hospitals, as John can speak to directly, to shift their operating models to accommodate these types of new solutions. And then I think it's also going to take policy and payments changes, because still to date, the systems by which providers are able to grow their business are not necessarily in alignment with, remote monitoring, continuous engagement of patients, and preventative health. So as the new policy agenda becomes clear and there's more shifts in payments, I think the expectation is that coupled with consumers really enjoying, frankly, not having to, drive 2 hours or having their caretaker take time off of work to take them into an appointment, the consumer satisfaction coupled with the changes in payments are going to have an enduring effect. And I think we'll see in the next few years that telehealth and remote monitoring adoption is going to grow. And, within the large health systems, we'll have entire new capacities and capabilities and people dedicated to that operating model, where today they're just trying to survive in this pandemic, manage vaccinations. It's still too early, so it's not sustainable by any stretch of the imagination. And device companies, to your question, Frank, at that point, the ones that are on the water are prepared, they're going to really see escape velocity and growth in their, technologies.
Yeah, kind of stating where the puck is going, not where it is. And I want to play off a little bit of what you said, Nima, and John asked you this question that came in from the attendees, and thank you, everyone sending in great questions. But this idea of what you said, Nima, of changing the systems versus integrating new innovations. Clearly, we're doing a bit of both. We have to do both. But John, I'd be curious with platform as it develops, like, how are you guys thinking about changing the healthcare system versus bringing a new technology into the existing system?
What a great question. And so, having worked in process improvement for 3 decades, automating an existent process just gets you a bad result faster. Right? So if you're looking at adopting new technologies, you have to ask, well, what process change would you want to make? And so there's a company, and again, I'm not here to endorse any company or service, so I want to make sure that's clear. But there's a company in Israel called Diagnostic Robotics who has developed what I'll call Waze for healthcare. Now, how does Waze work, right? Oh, we all have our phones, we all drive around, and then you say, I want to go from point A to point B, and it says, well, a million other people did that, and here's what they experienced, and here's probably the best path. So what Diagnostic Robotics did for the entire country in Israel is they said, let's look at millions and millions of people's care journeys, and then figure out for you what care journey is likely to work. What should you go to a PCP? Should you go to a clinic? Should you go to a specialist? What are the probabilities of disease diagnoses based on signs, symptoms, geolocation, time of year, those sorts of things? So you have to imagine that what we're going to do in terms of changing the nature of healthcare is build more chatbot kind of interactions that get you to the right level of care, sort of the right patient, right location, right care, right cost, right time, as opposed to just taking what we've got today and making it move faster. And that requires, as we've been talking about today, integration of all kinds of data sources, patient supplied, telemetry, electronic health records, with algorithms to help this navigation. And I think maybe that's for this world of telemedicine that we've all entered during COVID and will probably persist, our dream, care navigation that's easier than it is today.
So building off of that, and Nima, I want to ask you this because you've worked in the patient engagement space. A lot of that sounds like it would enable the patient, the consumer, whatever you want to call us and the recipient of care, to manage their interactions and manage their healthcare better. Is that the world we're going to? Is that the world we should be going to? Where do you see in like engaging patients the work on the patient versus the work on the health system?
Yeah, I mean, I think that question varies based on the kind of patient that you're dealing with, where they are in their age, healthcare profile. But, some themes that I think are becoming more clear based on what we've seen just in the last few months, where the whole healthcare industry has been changing faster in a year than it has in decades prior, is I think we are going to see a shift towards more home-based care. So, skilled nursing facilities, especially with the effect that the pandemic has had, there's going to be more care in the home, and that's going to become more patient-centric, and that's going to be enabled by telehealth. And I think there's good momentum there for particularly senior populations. They are going to have a home-based care environment on a growing basis. And when that happens, it's not just the patient. You have the home health agencies, you have the caretakers, and there are going to be more tools available for that patient and their caretaking team to support them in that home environment. And I think we're going to see a system evolve there, and healthcare systems that are built around that home-based care environment. I think on the middle age continuum of healthcare, where there's less of the chronic conditions and spend, those consumers, they're using Zoom and Teams for their jobs. They don't feel the need to go and take a whole morning off to go to an appointment that they can have virtually. So we're going to see more of that telehealth. I think whether those consumers are going to be in charge of their health and healthcare data, I think we're very, very long ways away from that, because I think, this data is, all over the place in most cases. It's not well structured. There isn't a way to really put that data in the hands of the patient in a way that they can quarterback their own care. So I think John's point about navigation is key. The health systems are going to leverage software to enable better care navigation and support for those patients, but the patient is still going to be shepherded through a new process that is more technology driven. I don't think that they're going to be necessarily in the driver's seat and in control. I think we're a long ways away from that still, frankly.
Indeed, indeed. Well, and Anne, what about, for the population that you work with? I have to imagine this data, not only is it useful for the clinician providing care, but to the mother, to the family as they're going through the pregnancy. What is it like from the, I hate to use the term patient in this case, but from that person?
It's really interesting. And I think Nima brought up a good point. So much of this is generational. And the patient population that we are really focused on, and let me say one thing, in my past life, I did focus on chronic disease management in the older generations, but I do think that there is a change that is coming, because the generation that I'm working with right now, everyone is very connected. They want to see their data. They're using their data. And having that patient that has the ability to actually see what's going on, understand a little bit more what's going on, have better communication with their providers, and more informed communication, I think is really going to help drive some of this change going in the future.
So that I think is a great segue into one of the other topics we talked about in preparing for this, which is that access and the potential for digital divide. That, right, we know there is a population in which digital technologies, telemedicine, they might be digital natives, have access to those tools. And then there are populations, whether it's by age, by income, by geography, by race, by other means, that have less access. And even in today's healthcare system, we know there's challenges. John, I'd be curious for you to talk about what are some of the kind of emerging digital divide challenges as we bring these new technologies and as we bring more care into the home, that maybe we aren't anticipating yet and we probably need to plan for and figure out?
Well, sure. Let me give you 3 examples. So as we deployed our home hospital platform in Florida and Northwest Wisconsin, what we discovered is in the US, there's quite heterogeneity of broadband deployment and availability. Even around urban areas, there's heterogeneity. And it's so fascinating because I travel the world, or did before COVID, and I could be in rural China and have 5 bars of LTE near a farm, but yet you can be 10 miles out of Jacksonville, Florida, and have limited access to broadband or even cellular. So that is something you need to keep in mind. And so how do you architect around that? Well, I mean, sometimes if they don't have broadband to the home, there is cellular, so you can use an LTE modem in the home, and all the signals just get sent over cellular, and it all works okay. In some regions of the world, though, you have to deploy some kind of creative strategies. In sub-Saharan Africa, bandwidth is limited and expensive. So what you end up doing is building software that does store and forward. You're in the rural community, you record the data, and then as you return to your home base, as soon as you get a connection, it's transmitted, and that works okay. Sort of interesting, in rural India, there is ubiquitous cheap bandwidth. So you have to engineer the platform, engineer your components to the environment in which you're working. So that's sort of issue 1. Issue 2, be very careful about mandating selected, what I'll call technology types or technology literacy. So imagine this, if we say we've got this brilliant, and I've been picking on Ann here, and we got this brilliant system, and all you need is an iPhone 12 and an Apple Watch. Well, how many users are there who are Medicaid recipients who have iPhone 12s and Apple Watch? And I just use this as an example to say, we want to be really careful. not to create a worsening digital divide or disparities of care by demanding certain levels of technology, especially those that are either expensive or require a lot of sophistication to use. So you have to engineer solutions that work anywhere. And so, of course, not only iOS and Android, but even ask yourself the question, can you use a feature phone? Can you implement your technology in simple texting? Are there alternatives like even using a piece of paper? And as we do the vaccine credentialing initiative work across the country and think of back to work and back to life with a common vaccine credential, you actually have to say, let's make sure it works just as well on a paper-based QR code as it does on a phone, so you don't create a worsening digital divide.
Well said. I'd be curious. Oh, Nima, did you have something you wanted to add?
I mean, I wanted to emphatically agree with John's point on connectivity. The US infrastructure and connectivity is not #1 in the world. And, when you think about where telehealth can make the best impact and actually, help be part of the solution for healthcare and economic inequalities that exist, if you look at rural America and the example that John gave, it is so true that you don't need to get very far from metro areas that don't even have good connectivity to realize that this telehealth vision can't be realized unless there is stronger connectivity. And that has to be, I think, at the forefront of our nation's agenda in the next few years, is to build and enhance that infrastructure, because the healthcare delivery system is only going to be as good as that infrastructure that it's riding on. And the second area in challenge, I think, is cybersecurity. In the last few months, we've had some major cybersecurity breaches and vulnerabilities exposed. As healthcare becomes more remote, as devices become more intelligent, they're administering treatments, information from these devices is being used to develop signals, as John said, and turn those signals into actions, and actions that are then executed automatically. We've got a serious, I think, national mandate to secure healthcare information and these devices from, outside attacks that are malicious. And that is a major challenge that is not going to discriminate and is going to affect everybody, regardless of whether they have good connectivity, higher income, higher tech literacy, higher education, to engage in these, new telehealth solutions. So those are two things that really worry me, from an infrastructure standpoint.
Yeah, I think I'm starting to hear this theme of the way healthcare could change, and thus the way that our respective businesses may need to change is not simply a factor of me innovating my product or you innovating your product, but changing the entire ecosystem or environment we operate in. And that whatever ecosystem we've operated in for the last 50 plus years, let's say, probably won't apply for what we need to operate in the next 50 years. And for our businesses to continue to be viable, we've got to think about that dynamic too. I want to play off of that broader topic and talk about the partnering side of this, or the collaboration, because it's clear even just from the three of you talking that your individual organizations are clearly working with more than just internal partners. I'd be curious for comment on, and maybe John, starting with you, given the Google relation, what is it like having a healthcare system interact with a large tech company? Is there a difference in thinking and approach to solving problems or to partnering? And then I want to ask that same question to Nima and Ann as well.
So one of the things that's been remarkable about Mayo Clinic is its understanding of how to partner with external collaborators. And that is, you need to set up appropriate guardrails and legal agreements. Conflict of interest needs to be minimized. Communication needs to be transparent, all these things. But instead of just saying no, you just say, here's how. And there's some guiding principles we've used. So for example, as I was outlining in the platform, the only data that we are storing in Google Cloud is de-identified and encrypted at rest. So that is to say, corporate partnerships where there are such safeguards in place make that partnership work. And you just need to ensure that all your stakeholders understand transparently what you're doing and how you're doing it and how you're keeping their data private and safe. Just to play off something Nima said, because I think Nima must have just read my article that I published yesterday called Wearable Danger. And it's on my blog right now if you want to look at it, geekdoctor.blogspot.com, where it says, as you partner with device companies, do you know what IoT really stands for? Internet of Targets. Right? You need to do all those security protections before you bring a partner into your firewall and ensure that the data that is coming in is uncontaminated and safe. So do these partnerships. They're critically important for innovation. Just make sure you have guardrails, both policy and technical.
Yeah, very good, very good. And Anne, what about in your world where you're bringing a hardware and a software solution, you're moving data back and forth? What has it been like navigating those different, organizations or groups that you have to interact with that maybe if it was a purely hardware product with no data moving on just wouldn't be there or wouldn't have been an issue?
Well, quite honestly, I learned a lot in just working with Mayo. So kind of playing off of what John just said, it is all about having those safeguards in place. It's all about having de-identified data, because quite honestly, medical technology is not going to advance, because I do believe that the data is actually going to drive some of the innovation that we have, particularly when you're looking at healthcare and machine learning types of algorithms. I think it's critically important. We've got to be able to have access to that data, but you have to have those safeguards. And quite honestly, as a company, I don't ever want to see identified data, but I still need to have it. So it's critical for the relationships that I have with the provider organizations. The other thing, though, that I do want to point out, there are some really, really innovative companies and technologies that are out there that sit in between the medical device companies and the providers and truly blind the data between the companies, but you can still utilize and share the data both ways between the provider and the device companies.
Indeed, indeed. And Nima, I'd like to ask you about the non-traditional entrants that have been coming into healthcare, right? So we've seen Google doing stuff, Amazon doing stuff, lots of big tech companies. Everyone's got a healthcare play today. Locally, we have Best Buy with a healthcare business now focused on senior care, for example. You work in a strategy role, among other things. When you look at the landscape and you see these retailers, tech companies coming into healthcare, what's your reaction to that? And what are you learning from that? And what are you hoping maybe that they're learning from all of you?
Yeah, I mean, complicated question with a lot of parts in there, Frank. I think, it's good to have competition. Okay, I think when, Amazon, which is, the US's leading e-commerce company, steps into pharmacy, you have to scratch your head and wonder, well, what could Walgreens, have already been doing, right? I mean, that there's some degree of complacency and inertia in healthcare that I think is fostered by the consolidation that favors these incumbents that are entrenched. And once they get to scale, there's so many high switching costs that makes it difficult to, partner with the little folks, that the bigger companies end up, getting more and more advantage until an external actor like an Amazon comes in, and then everyone starts to scramble. Right, you see CVS being more innovative since the news of Amazon's entrance into healthcare started to be propagated. So we need that external competition. Now, looking at partnerships, to your previous question, there are partnerships that I get excited about, and then partnerships that I just can't take seriously. And it comes down to recognizing, what are the core competencies that each organization is bringing to that partnership, and having a sense of also, is the organization ready for that partnership? So an example of this done wrong that I see too often with medical device companies, in not just Minnesota, but in the global sector broadly is, oh, we're just going to bring in IBM or this little AI startup, and we're going to, put this AI startup in. And what they haven't fundamentally realized is one, do we have the data at the base of the pyramid? Have we done the core work of structuring that data, wrangling that data? Have we taken the next level on the pyramid and actually gotten our house in order to where we can start to analyze that data? And then after we've analyzed that data, are we able to do predictive analytics on that data? And too often they don't think of, innovation and entering these spaces as like a layered approach. And when a competitor, a tech disruption feels like it's happening, I think there's this sort of sense of urgency, like, okay, we need to rush and we need to buy this AI solution. And, that actually just causes paralysis, because you haven't taken a systematic approach. So, in general, my thought is it's good that there's, incoming innovation into healthcare. This pandemic has accelerated that. I think a lot of companies have to slow down to make it on time. And they need to figure out what they have to do to develop their internal organization readiness, getting their data in order, and then figuring out how to partner. I think the Mayo Clinic Google relationship from the outside looking in, to me, is an example of a really well-structured partnership between two of the world's leading organizations, right? The Mayo Clinic has the healthcare expertise, it has the providers, it has the data, and it has longitudinal data. And Google, you don't want to compete with Google on algorithm design, development, and deployment, right? So if you can put these two things together in the platform that John is leading, I think that is, two mature organizations who've had their own separate learning experiences in healthcare and tech, respectively, coming together. And that's going to be, an exciting, partnership and represents, the best of, I think, the types of strategic partnerships that I would hope to see coming out of Minnesota companies.
I think that very well said, that it's not the technology, and it gets to your kind of very first point, that it is about the patient, about the outcomes, about what we're trying to do. The software, the technology is an enablement of that. Related, we've got a really good question from the audience that I want to ask the three of you, and it'll be a good way to start to come in for a landing here, which is they asked it as, we were using plain old telephone systems not that long ago, still landlines. I can remember trying to play my video games on a regular landline, and it was not fun. If we look 20 years ahead from now, and we recognize that there are these system changes we need to make, there are technology changes, there's a lot we need to do. But if you look 20 years ahead, how confident are you that we'll be in the world we should be or want to be in? And what is that, from your point of view or from your work, what does that world look like? And Anne, I'd love to start with you and hear, what does that world should it look like 20 years from now?
So here's an example. 20 years ago in cardiology, if you think of what's happened in 20 years in cardiology, it is pretty amazing. Now, would we like it to move faster? Of course, we all would like it to move faster. But 20 years ago, remote monitoring and looking at devices and data from the devices, it took a while. It took a while for everyone to get their head around it. And now we've got examples of, Preventive Solutions and all the news that just came out with them, and they're doing remarkably well. I think the next 20 years for us is really going to be about how are we using this data? And back to what Nima was saying too, in using the data in predictive ways and sharing that data and protecting it. But I think the next 20 years are going to be very, very transformative. But I don't know how quickly it will move at this point, just because we've got so many regulatory issues. There's a lot of cybersecurity issues that are going on right now. But I do think it's going to be very transformative.
John, what about you? What 20 years from now, will we be in the world we want to be in, and what does that look like?
Well, be very careful, because it's 1993 and there's this thing called the web. It's got 500 users. What do you think it's going to look like in 20 years, right? I predict 6 quarters. I forget more than 6 quarters. Pretty hard to go beyond that. But what Ann said is correct. The National Coordinator for Healthcare IT is Mickey Tripathi in the Biden administration. And Mickey is a good friend, Massachusetts-based. actually born on the same day I was. Mickey has a set of focuses that are very consumer oriented. One of the things he has to implement is the interoperability rule and the information blocking rule, which take effect in April. In effect, what those say is that no provider can exclude a patient-facing app from making a call to the patient's data in that provider's organization. So that means APIs are legally required, and in effect empowers an ecosystem where the patients are going to increasingly have data liquidity and data stewardship. So think about that. I now am in control of my own health and my family's health. What is it I as a consumer will demand? Well, Ann got it right. I'm not going to go to a doctor's office to have a diagnostic test done if it can be done in the home. A lateral flow assay that I run on my desk, take a photo with my phone, colorimetric analysis is done, I get a lab result. I mean, it's going to sound a little crazy to you all, but I'm on advisory boards of a couple of companies, and there's a company creating an in-toilet urinalysis device that decides who's peeing based on the Bluetooth low energy signal closest to the sensor, right? So you're going to see this world where lab tests of all kinds will complement with AI algorithms and the connectivity we've been talking about to deliver more remote care. And then we'll have to get into remote therapeutics in addition to remote diagnostics. Again, this is going to sound a little crazy, but hey, you gave me 20 years. Do you remember, Frank, when HP started to make printers? They were basically free, but the ink was really expensive. Well, why not if we're thinking of a future of therapeutics at a distance? We have 3D printers in our homes that dispense medications, and we just buy the cartridges that go into those printers, and every morning the pills we need are printed for us. So start thinking of an end-to-end delivery system that requires less on-prem anything and more distributed and home-based. All, we hope, taking ethics, digital divide and disparities into account. So it'll be quite the ride, but since Ann mentioned regulatory issues, we have a friend who is sitting in HHS who will help us get to where we need to be.
And Nima, I want to give you the last one on that to ask, what do you think the world will look like, whether it's 6 quarters or 20 years from now? But with one little nuance that just came in from the audience, which is, do you think that world will result in a lower total cost of care or not?
Well, I'll tell you what I think we need to make that world look like, and we all have a part in doing that. The first is we have to, come together and nail this issue of coverage, which is at the core of access, right? There's still, several million Americans who don't have access to care, and, they can't even get the treatments that they need and the medical devices supporting them want them to get, right? So we have to get the coverage issues figured out. I think the other issue that, with the Affordable Care Act wasn't addressed enough is about medical education. We have engineered scarcity, right? In some areas, we need to make sure that we have enough providers practicing at the top of their licensure to take care of a growing population. So that has to happen in the next 20 years, and then the payments reform and making sure that we are actually paying for treatment outcomes and continuing to move, the ball down the field in that area, I think is key. And what's going to happen as we do, more to, encourage adoption of technologies is that there will be more consolidation. The Mayo Clinic is one of the best hospitals in the world. John dropped off. I was going to compliment his organization again. They can afford to partner with Google and do big things. The rest of the healthcare industry doesn't operate the same way. It's a cottage industry that's highly fragmented and decentralized. And so we're going to see more consolidation. And I hope that what we will do while that consolidation is happening is that we'll harvest its benefits, which is that you'll have premier healthcare organizations that are able to provide better services and more individualized care, like the Mayo Clinic. But we also have to make sure that there's an environment that allows for competition and innovation. If the entire provider market or plan health insurance market is divided up between 5 organizations, it's hard to be a little startup trying to sell to them, right? If you're an Anschutz, right? So we need to make sure that, the regulations also, allow for some degree of consolidation while forcing these healthcare organizations to adopt new solutions. Otherwise, we'll stop seeing that kind of innovation that's able to catch on today because, every state has its own population health analytics startup, right? And they're, dealing with the local healthcare organizations. We need that level of fertility in the, innovation ecosystem. So that's kind of what I hope to see, the coverage reform, payment reform, as well as, continued management of, the economy so that you have the competition you need to foster more innovation. And I hope Minnesota, which has such a long history of innovation, we put the first heart transplant in at the University of Minnesota, the first pacemaker. I hope that we'll stay on the forefront of all of this, in the next 20 years and be that global epicenter.
Indeed, and that is a great place to finish this wonderful discussion on. I want to say a thank you to our panelists and a thank you to all our attendees. An overwhelming number of questions that tried to incorporate them all, but thank you so much. Again, this webinar has been recorded, so we will share it afterwards. Make sure you share it with your colleagues. John, Nima, and thank you so much for spending a little bit of time with us today, sharing your insights, and I hope you have a great rest of your day.
Thanks, Frank.
Thanks so much.
Thank you.